Hello, my name is Alice Warner. I'm the Chief Editor of Orthodontic Products. Thank you for joining us for today's episode of In the Sterilization Room with Jackie, where we talk to infection prevention expert Jackie Dorst about what you need to know to keep the orthodontic team and patients safe during the COVID-19 pandemic and beyond. For over 30 years, Jackie has been a consultant specializing in instrument sterilization and infection control and prevention in the dental setting, and she has degrees in microbiology and dental hygiene. She has been a featured speaker at the American Dental Association and the American Association of Orthodontists. Hi, Jackie. Nice to see you again.
Hi, Allison. It's good to see you. It's been a busy week as usual and lots of information coming out. So I'm thankful and grateful to Orthodontic Products and you for this video opportunity to talk to all of the orthodontists and orthodontic assistants out there.
Yep. So actually today we're going to field some questions from a doctor. So you've been getting a lot of questions just in general from the orthodontic community and the doctors, but you had some questions from someone we know very well, both of us, Dr. Jay Bowman from Kalamazoo Orthodontics in Michigan. Dr. Bowman is actually a member of the Orthodontic Products editorial board and has been a longtime contributor. And so he had some questions that he posed to you. And so we thought we'd use that for this episode to kind of, answer the questions that are on all orthodontists' minds. So to get started, his first question was about masking and face shield requirements. Are orthodontists and team members required to wear N95s in their offices and when?
Yes. Okay, so let me drill down in this. Are the team members required to wear an N95 face mask and face shield? And right now, the guidance and remember it's interim guidance from CDC and from OSHA during the pandemic, the guidance states that when you're doing aerosol generating procedures, that you should wear an N95 respirator. So that's the distinguishing with it. Now, we in the dental profession have added in the face shield during the PPE shortage because both procedure surgical mask and N95 respirators were in very short supply. Normally, those are single-use items. You would use one per patient.
Right.
But during the pandemic and with the PPE shortage, we are now in either that contingency stage of where treatment is contingent on whether we have PPE or not. And at the early stages, as we reopened our offices in 2020, we were in the crisis because we were so short. So having the face shield prevents the contamination of splatters, splashes, aerosols while you're treating the patient to the exterior of the procedure mask or the N95 respirator. And that allows us to reuse that mask without getting contaminated as we take it off and put it back on. And it extends the life of that mask. Now, as the supply chain normalizes with it, then we'll go back to best practices and the guidance with it, and those could well become single use. So the question is about N95 respirators. The only team members that need to be wearing an N95 in the orthodontic office are those that do aerosol generating procedures. So the orthodontist, when they're doing a debond, maybe to either remove the orthodontic appliances or to reposition a bracket, then an N95 respirator would be worn then. We've either put another mask over the top of it or the face shield, again, to help preserve and reuse those short supply masks with it. So the front desk wouldn't need to wear an N95 respirator. They can wear a level 1 or a level 2 procedure mask. Treatment coordinators, they don't need to wear an N95 respirator. And even with the clinical team, if all of the debonds are done in one area where you've set up, special precautions with it, then only that team member would need to be wearing the N95 respirator. So big difference about whether you're wearing normal PPE when you're doing a retainer check, an arch wire check, or an aligner, delivering an aligner, then you'll wear your clinic gown, mask, normal level 1, 2, or 3. Well, level 2 or 3, I shouldn't say a level 1. And then put on your safety glasses with it. And
Okay.
again, we've been preserving even those level 2s and 3s with putting the face shield on top of it. And of course, a new pair of exam gloves for each patient.
Right.
So I think that sort of gives an outline of who needs to be wearing those N95
Mhm.
respirators
Mhm.
in the office. It's only the ones only when you're doing those aerosol generating procedures.
Okay, great. Okay, well, Jay's second question gets into this is gonna, I know this one's gonna require a bit of an explanation. So what's the difference between aerosol versus airborne precautions?
Oh, yeah. Well, I just previously said, you wear those N95 respirators when you're doing an aerosol generating procedure.
Hmm.
Now, aerosols are defined as particles that are greater than 5 micron size particles.
Okay.
So they're heavy, wet particles that are expelled from the patient's mouth when we are maybe polishing with pumice, using a prophy angle, using an air water syringe. With Dr. Lindsay Marr at Virginia Tech, when she did her studies of how many colony forming units per milliliter are produced with different dental procedures, she identified using air water syringe as one of the highest.
Mm.
Even a greater number of aerosols were produced than using a high-speed handpiece with a water flowing through it. So a significant difference with that. So those aerosols are greater than 5 microns. They can carry the viral particles, multiple viral particles inside of each one of those heavy, wet droplets. And because they're heavy and wet, they settle out of the air pretty quick.
Okay.
And that's where CDC came up with that 6 feet of physical distance when you're not wearing a mask,
Mhm.
because it's believed that those heavy, wet droplets settle out. An airborne particle is less than 5 microns, and it's lighter and floaty. So you can imagine that small particle size keeps floating through the air and could go maybe even 20 feet away, or remain suspended for longer than those heavy, wet aerosol droplets would.
Mhm.
So determining how a disease is transmitted, whether it's in aerosol or airborne, is significant information to determine which precautions do you need to take
Right.
when you're generating those aerosols or airbornes with it. So it's quite an important factor to understand the difference between aerosols and airborne diseases and what the
Okay.
particle size is.
Hmm. Okay. And then in terms of the precautions at this point, is there a difference?
Well, yes, if it's, as CDC says, if it's an aerosol transmitted disease,
Hmm.
then there are no extraordinary mitigations that need to be done in the room.
Okay.
We're using high volume evacuation. If we
Mhm.
can use with an orthodontic procedure the HVE, then
Mhm.
it's going to remove 80 to 94% of the aerosols that are created, say, when you use that handpiece to do a debond.
Okay.
Um, and then we're, of course, wearing the PPE with the N95 respirator. Then
Mhm.
that's going to, any aerosols that remain. You can add extra oral suction to remove that additional 20 to 6% that the HVE didn't capture.
Mhm.
Now, if the disease is truly airborne transmission, and the research has established, such as measles. Measles is one of the infectious diseases that is airborne. Then those floaty particles are going to require more air mitigation precautions with it, such as having possibly a negative air pressure room,
Okay.
of having that requiring that extra oral evacuation. And with a negative air pressure room, all of the air would need to be expelled outside of the building. And then
Mhm.
once you leave that room, that closed off room, then you have to wait for amount of time determining on the air changes per hour for
Mhm.
your heating and air conditioning system for that room to be cleared before it's even safe to go back in and clean and disinfect the room.
Mm.
So there's a big difference between those heavy wet aerosol disease
Yeah.
transmission
Right.
and the light floaty airborne disease transmission. And at this time, more research is needed
Right.
before there is a definition of how the virus that causes COVID-19, the SARS-CoV-2 virus, is
Yeah.
transmitted. At this time, it seems that it's aerosol,
Hmm.
but more research is needed.
Right. Okay. So still take those airborne precautions where you can.
Well,
So,
yeah, where you can, but
mhm.
if it's determined, if OSHA writes into
Right.
a standard in the future that
Mhm.
it's airborne, it could be an expensive retrofit modification of existing buildings. Right now, the ideal would be that your building has 6 air changes per hour for existing construction, 12 air changes per hour for new construction with
Mhm.
it. And I've seen everything where orthodontists have gone in and tested the air in their office, that some had as low as 3 air changes per
Mhm.
hour.
Okay.
And of course, that was an older facility, about 30 years old. And
Mhm.
then everything, I know one orthodontist in Florida, when she had her building checked, she had 15 air changes per hour, even though the
Mhm.
building was 20 years old. So
Oh,
without testing and verification, you really don't know what you're working with. You don't know how much
yeah.
filtration and air changes per hour, and that's the number,
Yeah.
the how long does it take the heating and air conditioning system to move all of the air from a room through the filtration system and return clean air back into the room.
Yeah. Okay. Another question that Dr. Bowman had, which you might have already answered, but I think it's, I I think it's a very clear and concise question is there proof that COVID-19 has been transmitted either way, either airborne or aerosol?
There's been some research done,
Okay.
a few publications, a lot of comparison to different aerosol and airborne disease mitigation, but at this time, no, we don't have that definitive information. Viruses are very difficult to research,
Mhm.
unlike bacteria and fungus that you can put on a petri dish or in a test tube and incubate overnight and get growth and determine. I mean, you can actually see those sometimes the colonies with your eye, and then easily see them under a microscope. Unlike viruses, viruses require a live cell. Cell media, keeping those live cells alive in the laboratory is
Mhm.
very difficult. It's when I was in college, I was a work study student, and I was assigned as the research assistant to the virologist.
Mhm.
And so I learned firsthand how difficult it is to create that live cell culture and then
Mhm.
inoculate it with a virus and keep it alive. It
Yeah.
has to be closely watched 24 hours a day, 7 days a week. And it's a very expensive and difficult process to design virus studies. So right now, most of the information that we're looking at on aerosol and airborne disease transmission is either being taken from bacterial transmission, such as tuberculosis,
Okay.
or from other viruses that have been studied in the past. And of course, there's a whole SARS family of viruses.
Mhm.
The SARS-CoV-2 virus is just one of those. In years past, you may have heard of swine flu or
Right.
bird flu or MERS, Mideast Respiratory Syndrome. Those are all viruses that are in the SARS family. So over the last 15 years, research that has been conducted on how these diseases are transmitted has been used and sort of applied to the SARS-CoV-2 virus. But again, there's a big need for comparative studies and accurate information before new standards are implemented for infection control by CDC and for
Mhm.
employee safety by OSHA.
Right.
Yeah.
Well, the last question we have is once vaccinated, will we drop our protocols back to standard or universal precautions? And if so, when?
Oh, Dr. Bowman's asking me to look into a crystal ball. And unfortunately, my crystal ball is a little cloudy at this
Yeah.
time.
Yeah.
That's an answer that we would all like to know, because you've heard the phrase, when can we get back to our new normal? When can we get back to normal? What is it going
Mhm.
to look like in the
Right.
future?
Mhm.
Um, CDC has been aware of airborne disease transmission for many years,
Mhm.
and they've looked at it in hospitals, and hospitals have. That's where this isolation room or negative air pressure room comes from. Is
Mhm.
patients who are infected with airborne diseases. The precautions that have been developed there. In the future, we'll have to see what the research determines, but I truly believe that some airborne infectious protocols will be included in the CDC practices, recommendations, and guidelines for all dental offices as part of new infection control standards. And it's not just because of the SARS-CoV-2 virus, but all of the other diseases such as measles, mumps, rubella, pertussis. All of these diseases can be transmitted by aerosols, even influenza. And we've had the flu with us for years. So I think we'll see this in the future as there are new guidelines for infection prevention. Some sort of airborne disease transmission will become part of our standard infection control precautions in the office. I don't know how extensive those will be. Will we be required, say in the future, to continue doing these thermometer tests? And Dr. Bowman didn't ask about the thermometer test, but that's one of the questions that I've received so many calls about in the last 2 weeks. Mary Beth Kirkpatrick, even with Impact 360, she's an awesome orthodontic consultant with a depth of knowledge about the profession. She called me from one of her clients' offices this week and said, Jackie, how much longer are we going to have to continue testing these employees and patients? It's really impacting the schedule.
Yeah.
Well, a CDC for a number of years has recommended testing patients to see if they have a fever. And if so, then that indicates they're infected with something. It may not be COVID-19, but it could be that maybe they're going to break out with measles. Maybe, you know, their parent doesn't believe in vaccinations, or they fell behind on getting their vaccinations during the pandemic where they weren't going to the office as much.
Right.
And so for those diseases, I think, you know, if anybody who has a fever, and as CDC says, above 100 degrees, then we should reschedule them. Now, Mary Beth at the same time says, but Jackie, for the past year, this office has been doing those tests and they've only had 2 patients come in that had a fever. I think one of the lapses with these touch-free thermometers is that we haven't calibrated them. Everybody goes in and you get the tested and test at your temple, not at the center of the forehead with it, or possibly at the wrist with it. And it comes back 96.7. You're normal, good to go. Well, we know that the human at normal temperature is 98.6, correct?
Right. Yes.
So why didn't this device measure 98.6? Why did it measure 96.7 or 97.8?
Okay.
So it's not measuring accurately, and there's a variable about how close or far away do I have it. So it needs to be calibrated. And an easy way to calibrate it in the office is to take an old-fashioned in-the-mouth thermometer and take say an employee's temperature with it. And they're 98.6. Well, then what is the temperature with this? Oh, 97.6. So we know that we need to add 1 degree to calibrate this with what is the standard, correct?
Okay.
So if we're testing patients and they come in with a temperature of 98, they may have truly had a fever of 99.6 that we were not allowing for with calibration on the touch-free thermometer. So I would recommend to offices to calibrate their thermometer, know what they need to add to be at the normal temperature, and they might discover that they have more patients coming in that do have a fever that they've been missing. And again, it's not just because of COVID-19. They could have one of those other infectious diseases. So patient symptoms, treating patients who are ill, I think that's going to be an ongoing concern, is how we review the patient's status at that time as they come in for appointments. And I'm real hopeful that all of those computer software companies and hardware companies that are out there come up with a symptom or an application, I should say, that as patients log in for, I'm here, ready for my appointment, it asks them, do you have any symptoms? And it has a built-in thermometer that is calibrated and automatically says, temperature normal, you're good to go.
Yeah, we might get there. So.
Yes.
All right.
Yes.
Well, thank you, Jackie. I think that's really helpful because, you know, I know a lot of these questions you're probably getting from multiple doctors. So they're definitely out there. So thank you so much. We will be back in a couple weeks for the next episode of In the Sterilization Room with Jackie. In the meantime, to catch up on past episodes or to check out the latest orthodontic industry news, please visit our website, orthodonticproductsonline.com. Until next time, take care and stay safe.